Welcome back to my History of Renal Medicine lecture series, in which we explore the colorful history of our understanding of one of the most important organs of the human body. You'll probably remember this quote from H.A. Christian from my previous lectures. I'm pleased to say that in this lecture, not only will we be closer to the goal of overturning this notion, but we'll also get to know its author a little better. To contrast that quote to what lie ahead, in only 50 years' time, a man named Jean Hamburger would state in dramatic form, the history of nephrology of the last 25 years could be entitled The Decline and Fall of Bright's Disease and the Birth of Individual Renal Diseases from its Ashes. Before we get started, let's quickly review the major figures and events of our previous lectures. There was Marcello Malpighi from the 17th century, Giovanni Morgagni in the 18th century, and Richard Bright and William Bowman in the 19th century. They took us from the discovery of the subunit of the kidney, through the revelation that depictable changes in the kidney were associated with treatable disease states, to the discovery of the microscopic structure of the nephron. These findings, when coupled with technological advances in histology and diagnosis, would pave the way for the discovery of post-scarlatinal renal disease, renal amyloidosis, and hypertensive nephrosclerosis, all of which would help accumulate the data needed to prompt Volhard and Farr to publish a clinical pathologic treatise in the classification of diseases of the kidney in 1914. This was the first of its kind, and a very good start, but with some limitations. Limitations notwithstanding, it would earn Farr the title of the first modern renal pathologist. And with all of that in mind, I'd like to say that I'm Matthew Tortora, and I practice diagnostic pathology in northern New Jersey, serving Cooperman-Barnabas Medical Center and Clara Moss Medical Center. This is the fifth in a multi-part lecture series on the history of renal medicine, which I've given to the departments of pathology, medicine, and humanities at Cooperman-Barnabas Medical Center. This is part one of the third lecture entitled Needles, Nodules, Aldehydes, and Electrons. Before and after Conrad Pirani. Let's get started. At this point in our journey, it will be helpful to drill down on the microanatomy of the filtration unit of the kidney, the nephron. This is what it looks like in 3 dimensions. The glomerulus, its centerpiece, is made up of a ball of capillaries. On the left, one can see 2 arteries, one of which delivers yet-to-be filtered blood to the glomerulus, and the other which newly filtered blood exits. The glomerulus is surrounded by a single layer of cells forming a capsule, Bowman's capsule. That tight space between the glomerulus and Bowman's capsule is called Bowman's space, or urinary space. It collects the filtrate from the blood, now called urine. And on the right, one can see a longitudinal cross-section of a tubule, called the proximal collecting tubule, which leads the urine away from the glomerulus and towards the greater collecting system. This is what it looks like in a 2-dimensional schematic. As before, the small arteries entering and exiting the glomerulus are on the left, with arrows indicating the direction of blood flow. On the right is the proximal collecting tubule in yellow. The capillary loops are in the center. The cells lining Bowman's capsule are in blue and are in continuity with cells in green called podocytes, which reflect around the outside walls of the glomerular capillaries. Anchoring the glomerular capillary loops to each other and to the wall are a clump of cells in purple called mesangial cells. Now let's take a trip to a new world across the ocean from where we've thus far spent much of our time. In this new world, a European explorer named Verrazzano, sailing for France, would set his eyes on the shoreline of an island that would have looked like this. For reference, this would have been about the same time that Vesalius was performing his post-mortem dissections back in Europe. Over the centuries, the island would grow and grow into the most famous city in this new world. And right about the time when Richard Bright was crossing over the New London Bridge into Southwark, A small outpost had propagated along the edge of a great lake in that new world, which would eventually grow into a city that looked like this. These new cities, and others like them in this new world, will form the backdrop for much of the rest of our lecture series. Now I'd like to take you out of a place and into a time. The image you are looking at is a still shot taken from the world's first film. It had a length of only a second or two, but it would be emblematic of a period of 20 years or so, which was so flooded by technological innovation that the modernity it unleashed would create a world that would have been virtually unrecognizable to any society that had existed before it. Among many, the light bulb, the telephone, the automobile, and last but definitely not least, the vacuum tube and the biopsy. Two inventions that would have an enormous impact on the advancement of diagnostic renal medicine. One of the earliest iterations of the vacuum tube was invented by physicist William Crookes and colleagues around the 1870s. It consisted of a glass tube with a partial vacuum, with two electrodes, the cathode and the anode, positioned on the left and bottom of the tube. When voltage is applied between the electrodes, so-called cathode rays are projected from the cathode. The shadow of the Maltese cross on the right helps orient the observer to the path of the electrons. The particle unit of the cathode ray would soon be revealed as the electron. Crookes' tube would also be used in the discovery of X-rays and then later modified into the cathode ray tube. It was William Röntgen who used the cathode ray tube to fire electrons at a plate coated with a photovoltaic substance. The first image ever taken was of his wife's hand. Upon seeing the image of her own skeleton, she was said to have exclaimed, "I have seen my own death." For this, Röntgen won the Nobel Prize in Physics. In 1933, Ernst Ruska would modify the cathode ray tube to create this electron microscope. In a nutshell, the device featured a voltage source which fired electrons in a vacuum through a series of lenses and then through a portion of a very thinly sliced specimen of interest to obtain an image. This technology increased the ability to magnify images from hundreds of times in size to thousands or even millions of times. Here is a scanning electron microscopic image of the microvasculature of the kidney after digestion of the background tissue. The concept of the glomerulus as a ball of capillaries should now be more clear than ever. In my framed portrait celebrating the many different types of electron microscopy apparatus, one can clearly see an image of Ernst Ruska in the upper left corner. As we look upon this photo of Ernst Ruska preparing to receive his Nobel Prize for the invention of the electron microscope, it's important to note that in the decades that followed, this device would become, and continues to be, an integral component in the pathologic workup of medical renal biopsies. Speaking of the biopsy, the first ones were open biopsies, that is, they were performed with a scalpel. In 1875, the first biopsy was performed, and in 1879, the term biopsy, bios, life, plus opsis, a site, was coined. It was Eugene Hand who performed the first kidney biopsy in 1881. He was one of an assortment of German contemporaries who pioneered a number of medical firsts, including the first gallbladder excision, the first colostomy, the first thoracotomy, first resection of the rectum, first excision of the stomach, and first bladder scope. Now, as we cross the threshold of the 20th century, let's spend some time touring the most notable diagnostic achievements in renal medicine, which preceded the arrival of the central figure of this chapter, Conrad Pirani, in the mid-part of the century. In a previous lecture, we learned about Gabriel Valentin with his microscopic discovery of a grayish substance in the kidneys of some patients with protein in the urine. That grayish substance was made of lipid-filled macrophages. By 1905, the term nephrosis was applied to patients with protein in the urine. And in 1913, the term lipoid nephrosis or nephrotic syndrome with, quote, minimal lesions was coined to describe patients with protein in the urine, a whitish substance in the kidneys, and microscopically normal glomeruli, glomeruli with so-called minimal microscopic changes. Today, it would be called minimal change disease. Here's an image of the first renal biopsy taken with the intent of diagnosis in 1923. The image on the right purports to show a glomerulus affected by amyloidosis. In 1925, in the article Pathologic Anatomy of Bright's Disease by Theodore Farr and colleagues, the so-called hyaline degeneration of the glomerulus is described by Farr in some patients with Bright's disease. Hyaline refers to its pink, glassy appearance as seen affecting the lower glomerulus in this image. By contrast, the upper glomerulus in this image is normal. Here's a higher power view of the glomerulus with that same pink consolidated change. Today it would be called focal segmental glomerulosclerosis. Focal meaning only some glomeruli are affected, and segmental meaning only part of a glomerulus is affected. Also in 1925, Moskowitz published a case report of a young girl with a triad of symptoms including fever, anemia, and central nervous involvement. On autopsy, thrombi were present in the small blood vessels of the kidney and other organs. Later, thrombocytopenia, or low platelets, was added to the triad. This specific disease would later be called TTP, and the term thrombotic microangiopathy would later be coined to describe the microscopic changes that took place in the kidney and other organs in diseases like this. And also in 1925, H.A. Christian, whose quote from 1922 has no doubt been imprinted on your visual cortex, came up with his own rudimentary classification scheme that included acute, subacute, and chronic nephritis. In 1927, at St. Mary's Hospital in London, the same place that his colleague Dr. Fleming had discovered this substance, penicillin, a doctor named Cecil Alport would describe a hereditary kidney disease. He would learn that this hereditary kidney disease was also associated with deafness and affected males more severely than females. Although today, with advances in kidney transplantation, male patients can live normal lifespans with a high quality of life. This disease would come to be known as Alport syndrome. You may remember the bright red aniline dye called Congo red from our last lecture. In 1927, at the University of Liège in Belgium, amyloid plaques from patients with Alzheimer's disease were stained with Congo red and then placed under a polarized light source, revealing a bright apple green birefringence for the first time, providing further specificity in the diagnosis of amyloidosis. In the years that immediately followed, doctors would discover the first case of familial amyloidosis and would make an association between the Bence-Jones protein mentioned in our previous lecture and certain cases of amyloidosis. Now on to a sweet taste. In the medieval period, a group of men claimed they were able to diagnose one's ailments by analyzing the properties of urine. They evaluated its color, the presence of foam, and even its taste. To such an esteemed group of scholars, only a title of the highest honor would do, and so they were called the piss prophets. The piss prophets noted that in some individuals the urine had a sweet taste. These patients had diabetes. Our understanding of diabetes has evolved since the time of ancient Egypt, through Galen, Morgagni, Willis, Dobson, and Bright. By the 1880s, doctors had discovered a way to induce and then reverse diabetes in experimental models on dogs. Sadly, though, until the 20th century, this was a uniformly fatal disease, mainly affecting children. The so-called treatments included a barbaric type of caloric restriction, the first starvation diet of its kind, with patients sometimes dying of malnutrition even before the disease could kill them. It happens that in the years preceding the work of Conrad Pirani, perhaps the most celebrated advances in the diagnosis of renal disease occurred in the area of diabetic disease. And as you will see, this was not by chance, because in 1922, insulin was isolated for the first time. In January of 1922, doctors walked into a hospital in Toronto, Ontario, and injected a 13-year-old boy actively dying of diabetes with insulin extracted from cattle. Eventually, his blood sugar normalized, and he was no longer in a state of terminal disease. In the words of Dr. John R. Williams, the first doctor to administer insulin in the United States, few recoveries from impending death more dramatic than this have ever been witnessed by a physician. Here is a photo of his first patient, James Havens, right before insulin administration, near death and dying in a state of active starvation. And here is a photo of him 8 years later, holding his child. Some have claimed that the doctors who isolated insulin saved the lives of hundreds of millions of people over the ensuing 100 years. Now that diabetes was no longer a terminal illness, the chronic changes it caused in the kidneys and other organs could now be studied. It was in 1933 that Dr. Frank Burr Mallory, director of pathology at City Hospital in Boston, would found the Mallory Institute of Pathology. Subsequent directors would include his son, George Kennedy Mallory, and Stanley Robbins, whose legacies would include the discovery of Mallory's hyaline in the liver and the Mallory-Weiss tear in the esophagus, and the publication of the most iconic and ubiquitous teaching text in all of pathology, Pathologic Basis of Disease, still used to this day to teach medical students. And it was in the very early years of that institution that Paul Kimmelstiel would enter our story, arriving at the Mallory Institute in 1934 after training under Theodore Farr. As luck would have it, in the same year, he would run into a man named Clifford Wilson, who was in a traveling fellowship at Harvard. And in 1935, they would publish their seminal paper entitled Intercapillary Lesions in the Glomeruli of the Kidney, in which they described the rounded, hyalinized, acellular nodules that form in the glomeruli of a patient with advanced diabetic renal disease. Today we refer to these nodules as Kimmelstiel-Wilson nodules. Here is the photomicrograph from that original paper. And here is a photomicrograph I captured from a contemporary patient. In the words of a medical historian, quote, "This paper has now become a classic, but it led to considerable confusion in the next 15 years when, according to one writer, the Kimmelstiel-Wilson syndrome came to mean all things to all men. In addition to the nodular lesion, the eponym was used for a diffuse process involving the glomerulus, for the so-called exudative lesion, and even for the clinical picture of diabetic nephropathy. But despite this confusion, this landmark paper is notable in that it drew attention to a specific diabetic renal disease separate from atherosclerosis." In 1942, Theodore Farr would add to this picture by describing the diffuse lesion of diabetic glomerular disease. That is, the tendency of the mesangium, that matrix which tethers the glomerular capillary loops to each other and anchors them to the wall, to diffusely expand in diabetic patients. Within 2 decades, Alexius Thomson Bell would further expand our scope of understanding about these diffuse lesions with some axiomatic propositions that diffuse lesions were essential and specific components of diabetic glomerular disease. Nodules were always associated with diffuse lesions, but diffuse lesions were often found alone. Diffuse lesions could progress to complete obliteration of the glomerulus without ever forming definitive nodules. Nodules developed from the diffuse lesions, and thus it was impossible to make a clear distinction between the two. And he suggested that the term Kimmel-Still-Wilson lesions should be restricted to nodular intercapillary glomerulosclerosis. And with that, let's bring this lecture to a close in the year 1939. This is the year that a young man named Conrad Pirani, born in Italy and trained at several storied institutions, including the University of Bologna, would flee the persecution of the fascist Italian government for the United States and find his way to Chicago and New York. The story of his journey and his seismic impact on the field of renal medicine will be covered in depth in the next lecture. If you enjoyed this presentation, want to see more of the lecture series, or have questions about the history of medicine or of pathology, please feel free to contact me.